Conference record has joined the conference.
Hello?
Hello.
Hi, everyone. Thanks for joining us. We're going to get started in a few minutes. We're going to just wait a little bit for people to get on. Please remember to press *6 to mute your phone so that we don't have any background noise. And we have a great presentation planned for you, so just press *6 and then #6 again to unmute your lines when it's question and answer time.
Good morning. It's Ken Duckworth.
Hi, Ken. It's Emily.
Good morning, Emily. Is the good Dr. Ablon on?
Hello there. I'm here. Did I successfully unmute myself?
You're doing great. You're doing great. Thank you so much for donating your time to NAMI. We appreciate it. I've been following your career from afar, and I'm very grateful that you're going to share your expertise with the NAMI community.
Thank you. It's my pleasure to be invited to do so, so thank you for having me.
We get all-stars, on the NAMI little Friday call. So I've been the medical director for more than a decade, and I started this call, and we just get the best thinkers. And every new idea, it's just such a pleasure to bring new thinking in.
Well, I'm honored to be a part of it. Thank you.
Well, super. Well, good morning, everyone. This is Ken Duckworth. I'm very fortunate to be NAMI's medical director. This is the Friday call, and today's guest is Dr. Stuart Ablon. Stuart is a psychologist and is the director of Think Kids in the Department of Psychiatry at the Massachusetts General Hospital. He's also written some creative books on collaborative problem solving and working with kids who are explosive and otherwise challenging. So Dr. Ablon, is really a very leading thinker in the area of working with challenging young kids and finding ways to use words and strategies to help them in many ways. So what I'm going to do is have the good Dr. Ablon give us about a 15-minute or 20-minute greatest hits of his work and his thinking. I realize that's never enough time. And then we'll have time for questions and answers afterwards. I'm going to ask everybody on the call to hit *6 so you can mute your line while doing adventitious tasks, doing dishes, talking to someone else if you need to, because this is modern life. These calls are recorded, and they live on NAMI's website at www.nami.org/askthedoctor for people who happen to not be free at 11 a.m. Eastern Standard Time. Dr. Stuart Ablon, I want to thank you again for your generous donation of time, and I look forward to learning more from you. So take it away.
Thank you very much. I appreciate the introduction, and I appreciate everybody taking time out of their busy schedules to spend a little time with me and hearing about our work. As was mentioned, I work at Massachusetts General Hospital in the Department of Psychiatry there, where we teach people a particular approach to understanding and helping kids who exhibit some pretty challenging behaviors. And it's an approach that really applies to all ages and a variety of different challenging behaviors. We certainly, I think, are particularly known for our work with quite explosive, aggressive, defiant, oppositional kids and adolescents. But over the years, we found that the approach has been just as helpful with the kids who tend to implode more than explode. So what I hope to do in 15 minutes or so is to just sort of give you an overall sense of what this approach is all about, and then I look forward to the discussion. The first thing to know about the approach is that it's an approach that really flies in the face of conventional wisdom. Because the conventional wisdom about kids who behave in a challenging way is that they are behaving this way, first of all, because it's their parents' fault, that their parents have parented them poorly, and as a result that they have learned that they can use their difficult behavior on purpose in a willful way in order to get stuff that they want or avoid stuff that they don't want to have to do. And conventional wisdom tends to guide people's strategies for working with these youth, whether that's in a treatment program, whether that's at home as parents, or whether that's at school in terms of traditional school discipline. Most approaches to addressing tough behavior generally revolve around the use of rewards and consequences to try to motivate these kids to behave better, safe in the assumption that the reason they're not behaving well is because they're really not particularly motivated to, that they're doing this on purpose. Well, the interesting thing about this is that there's about a half a century of research in the neurosciences that has actually shown conventional wisdom to be flat out wrong when it comes to these kids. What it's really shown is that these challenging kids, they actually don't lack the will to behave well, that actually what they lack are the skills to behave well. And more specifically, what's been shown is that these kids tend to struggle with skills like flexibility, frustration tolerance, problem solving. It's as if these youth have a learning disability, if you will, in those domains. So instead of reading, math, or writing, this is just like a learning disability, except it's areas like problem solving, like flexibility, like frustration tolerance. And while that's sort of thinking outside the box still, I think it's useful to reflect upon the fact that, we used to have it wrong with kids with learning disabilities like dyslexia. We used to think that those kids were lazy and unmotivated to read. And of course later discovered that ironically those kids are probably trying harder than anybody else to read because it doesn't come naturally to them. And that in fact what they're lacking is some of the skills required to do things like decode words. Well, all the research has shown that the same is true with kids who exhibit very challenging behavior, except that their skill deficits are in those domains I talked about. And more specifically, what we found is that these youth tend to have difficulty with executive functioning skills, with language processing skills, with the skills required to regulate or manage your emotions, with flexibility skills, and with social thinking skills as well. And so really, what our work is about is trying to help shift people's thinking so that they see these kids in a much more accurate, humane, and compassionate way. And then to go about really, in essence, treating the challenging behavior like you would try to treat any other kind of a learning disability. And what that means is, well, the first thing you do if you suspect a learning disability is do an assessment and try to get to the bottom of whether there are skills that the kid is struggling with. And if, lo and behold, you find that there are skills they're struggling with, well, then what ends up happening is you try to use some kind of a different approach to teaching them the skills that they lack, because clearly sort of the standard, approach hasn't gotten the job done. And you have to teach those skills, of course, starting where the kid is at and teaching them incrementally in doses they can handle. So that, in a nutshell, is really what this approach we call collaborative problem solving is all about. It's first and foremost assuming these kids lack skill, not will. It's doing an assessment to figure out, well, which skills in those different domains I mentioned, executive functioning, language processing, emotion regulation, flexible thinking, social thinking, and really trying to home in and get some specific information in those areas. And then what that allows you also to do is to be very clear about when the challenging behaviors tend to occur. Because just like any other learning disability, what we find is that challenging behavior doesn't occur out of the blue for no reason. It happens when kids are asked to do stuff, or when a demand of some sort is placed upon them, when they're confronted with a situation of some sort that requires those very skills that they struggle with to handle it well. So in other words, if somebody has the skills to handle what's put in front of them, they're going to behave adaptively. And if they don't behave adaptively, well, that signals to us that they're probably struggling with some skills required to handle those demands. So we helped people not only figure out which skills they're struggling with, but to really make real specific lists of what are the types of chronic triggers, chronic expectations, demands that the kid's having a hard time handling. And by doing that, you actually, in essence, really make the behavior much more predictable. And when it's predictable, then you can make a plan. And we provide, in this approach we call collaborative problem solving, we basically provide a pretty simple framework for prioritizing and helping people see that at the end of the day, when a kid's not meeting your expectations or doing something you don't want them to do or not doing something you want them to do, at the end of the day, you really got three options. You can try to make the kid do what you want him to do, you can try to work it out with him collaboratively, or you can drop your expectation or shelve it for now, not forever, but temporarily. And in our approach, we call these your three plans. We call it Plan A, when you try to impose your will to get the kid to do what you want him to do. We call it Plan B, when you try to solve the problem collaboratively with the child. And Plan C, when you drop your expectation strategically, at least for now. And what we do is we help people see, what Plan A does for you and doesn't do for you. Same for Plans B and Plan C. And what people start to realize is that the most popular adult response to a kid not meeting our expectations is usually Plan A. Whether it's nice A or harsh A, it's usually an attempt to try to make the kid do what we want him to do. And while that's a way to pursue your expectations, it actually tends not only to not address the challenging behavior or decrease it, it tends to actually cause it, and in many cases triggers these kids and leads to some of the most challenging episodes. But the other thing is it doesn't exactly help the kid practice the kind of skills they're struggling with. Now, dropping your expectation, what we call Plan C, is a good way of stabilizing things and reducing challenging behavior, but that's actually not addressing the lagging skills either. So we spend most of our time teaching people about this thing we call Plan B, which in a nutshell is helping adults to practice solving predictable problems collaboratively with kids so that the solutions are mutually satisfactory. So in other words, solving the problem in a mutually satisfactory and realistic or doable way. And we provide sort of real, simple yet complicated structure to this. So there's really sort of three ingredients to the process where it starts by the adult listening very empathically and asking questions, taking guesses if need be, reflecting and clarifying what they're hearing, providing a lot of reassurance to calm the kid if needed, to try to get the child's concern or perspective about a problem on the table first. Before then, in the second ingredient, the adult shares not their solution to the problem, but their concern about the problem. And the third ingredient then being where the child is invited to brainstorm solutions together with the adult aimed at solving the problem, again, in a mutually satisfactory and realistic way. And what we find is that as you go about doing this problem-solving process, you can start to solve some of those problems that lead to the chronic challenging behavior. And, of course, then you start chipping away at things, and slowly but surely you start seeing a lot less challenging behavior. But the other important things that we see is that we see that the relationships between the adults and the kids start to get changed and enhanced in a very positive way. That in clinical language, what we like to say is we foster a helping alliance, a helping relationship with the child. Because, of course, some of the challenging behavior that these kids exhibit make it really hard to have a relationship that doesn't feel anything but conflict-ridden. So this process not only is aimed at solving problems and decreasing challenging behavior, but it's aimed at rebuilding or building or restoring a helping relationship. And the last, and certainly not least thing that this process is aimed at, is helping the child practice the very skills that they struggle with that are leading to the challenging behavior in the first place. So sort of baked into the ingredients, if you will, of this process we call Plan B is a ton of skills training. So there's practice and guided practice and modeling all throughout those three ingredients that help the child to practice letting people know what's bothering them, staying calm in the midst of frustration, taking somebody else's perspective into account, knowing how they come across, empathizing, trying to generate solutions to an idea, reflect upon how those solutions are going to work before you run with them, coming to a different solution than you first thought you would. In other words, you may notice that what I'm talking about here are executive functioning, language processing, emotion regulation, flexible thinking, and social thinking skills. So it's a very different take on skills training. Rather than sort of doing what you might call didactic skills training, trying to sort of impart different skills to the child in some setting that you want them to go then practice in real life, these skills are practiced in real life with the real adults in the child's life, and they're practiced in the context of this relational process. And so it's the repetition of this process, this relational process, where you start to learn more about where the kid's lagging skills are, and the child gets a lot of practice with them. And one additional side effect of this is that it's not only the child who gets to practice all of those skills, we adults have to practice them every time we end up trying Plan B with these kids. So that, in a nutshell, is what this is all about. And it's an approach that started as a parenting approach. It was then used in some therapeutic facilities like inpatient units, and then residential programs started to express a lot of interest, schools, both therapeutic schools, mainstream schools. We started to do a lot of work with foster care agencies. We worked in correctional facilities. And the approach has grown to the point where it really appeals to what are referred to as systems of care, where sets of systems want to come together around a shared philosophy, shared language, shared process, shared goals, to try to understand kids the same way and have a similar process to work with them. So we have whole regions now that use this across all their systems, whether that's corrections, inpatient, outpatient, residential, etc. So what started as a parenting approach has sort of grown out dramatically from there, and we've been collecting data along the way, and some pretty amazing results have been achieved across all those different types of settings. And I must say that the reality is that the amazing results are probably not due to everybody getting spectacular about that process I called Plan B. It probably is a lot more having to do with people shifting their thinking and the adults around these kids getting to, as I said before, a much more humane, compassionate, and accurate view of what's going on for these kids. And in essence, that's why maybe the most powerful part of this approach is the philosophy that underlies it. And that philosophy is a pretty simple one. It's what we say the philosophy is kids do well if they can, which is pretty simple. Kids do well if they can suggests if a kid could do well, he would do well. If she could do well, she would do well. And if she's not doing well, you know what? Something's got to be standing in her way. And our job as parents, teachers, helpers in these kids' lives is to figure out what's getting in their way and figure out how to be helpful. And while that sounds like common sense, unfortunately, still in this day and age, despite all we know from the research in the neurosciences, unfortunately, the more common way of thinking about these kids is still much more along the lines of kids do well if they want to. And if you believe kids do well if they want to and a kid's not doing well, behaving maladaptively, then you're going to be in the business of trying to make him want to do well. And I know that sounds sort of crude, but again, a lot of common parenting strategies, traditional school discipline, a lot of therapeutic approaches are really aimed at trying to make kids want to do well, motivate them to behave better, safe in the assumption that they're just not trying hard enough. And we come at this from a totally different vantage point. Our feeling is, ironically, the well-behaved kids that everybody, calls such good kids because they're so compliant, ironically, they don't deserve the kudos, because the reality is they're not trying very hard to behave well. It just comes naturally to them. And just like the kid with the reading disability who has to try harder than anybody else to read, these challenging kids are trying harder than anybody else to behave better. They don't need more motivation. They've got the will to behave well. They need the skills. And so the lion's share of our work is helping shift people's thinking from kids do well if they want to, we just got to make them want to kids do well if they can, to if he could, he would. And if he's not, it's got to be more complicated, then he's just not trying hard enough. Let's figure out which of these skills is getting in his way and how we can help him build those skills.
What about with mine then?
So, with that, I think I'll turn things over perhaps back to our host and see what questions and comments folks might have.
Thank you, Dr. Ablon. So as you know, for those of you who are regular listeners, we have no coherent way to organize a queue. Just breathe, be patient. We'll do our best to get to everyone's questions. We have till noon. So if you're comfortable, if you wouldn't mind saying your first name and where you're from, that would be nice for our host. But as the call is recorded, if you don't feel comfortable, just sing out your question. Okay, take it away.
Peter.
Go ahead, Peter.
It's Pete. How are you? Thank you, Doctor. Very, very, very much appreciate everything you've said. My question is regarding OCD behavior, where my son will say to me, "Hey, Dad, I want to go through this formula that I figured out and what I want to be when I grow up." And he's 19 years old, and it's the same thing every time. You know, day after day after day, 15 times a day. Have you applied this theory to that kind of thing, not just an explosive behavior issue?
Great question. Thank you, Peter. And it certainly sounds like you got a lot you're contending with there. Talk about sort of chronic issues. It sounds like you're waking up each day to confront sort of the same struggle with your son. We certainly have applied this to sort of a much wider range of what you might call challenging behaviors than just explosions. And what it sounds like you're describing, I'd call sort of perseverative and obsessive behaviors. And whether that qualifies officially for a diagnosis of OCD or not, we certainly have worked with a lot of kids of all ages who tend to have this perseverative, obsessive style, and that falls under the category of what I described as cognitive flexibility. There's sort of a particular flavor of flexibility is being able to move off of a thought that you have and to not get stuck, like we used to say about a sort of broken record. And without hearing a lot more about what's going on for your son, I do think that it is likely that a Plan B process can be of help with somebody who is sort of getting stuck in their thinking along those lines. And obviously, collaborative problem solving is not the only intervention that can be helpful for obsessive behaviors, particularly on the order of OCD, but there's certainly a place for it.
Thank you very much, Doctor.
Sure.
Other questions for Dr. Stuart Ablon? Dr. Ablon, while people are pondering, can you help us think about different diagnostic challenges and how you think about your work? Is it a trans-diagnostic approach, or do you encourage families to customize their approach based on the vulnerability of the child?
Yeah, great question. I actually thought of sort of diving into that with Peter's question. We don't tend to think diagnostically in the traditional sense. We find that, unfortunately, many times diagnostic categories are a bit of a dead end for people, and that they don't get specific enough. And so we do really try to individualize the process and tailor it to each kid's particular lagging skills. And, so whatever the diagnosis is, we got to take one step of a deeper dive. And it's true of those categories I mentioned too. I mean, knowing that a kid has ADHD and ODD, attention deficit hyperactivity disorder, and oppositional defiance disorder, which used to be a frequent, combination of diagnostic labels, that's not particularly helpful. Now, saying that the kid has executive functioning difficulties and emotion regulation difficulties, that's, not particularly helpful either. You really got to get more specific. And I can share at the end, if you want, some resources where people can go on our website to download some of materials like our assessment procedures, where we really try to break it down into much more, fine-grained analysis. So, with executive functioning difficulties, we want to know, does the kid have a hard time shifting gears from one thing to the next? Does the kid have a hard time holding multiple thoughts or ideas in his head at one time? Does the kid have a hard time stopping and thinking before he acts? And those are just examples. And with cognitive flexibility, too, we want to know, is that the flavor Peter was talking about, that a kid gets stuck, ruminates, obsessive, can't move off of a thought? Or is it more that they have a hard time with any change in routine or anything unpredictable or ambiguous? So we really want to drill down and get more specific in that way. And, the nice news is that we have found that the process is helpful across a wide variety of diagnostic categories. I think of kids on the autism spectrum are, in some sense, poster children for this approach. But on the other hand, we find it very helpful with kids with mood and anxiety disorders, kids with disruptive behavior disorders. So, a real wide range. And the reason for that is, I hesitate to even call it a treatment model, because it's really more of first a mentality and then a corresponding relational process. So it makes sense that a relational process could have relevance across all kinds of different diagnoses.
Hey, this is Peter again. I'm sorry, I don't want to take the whole thing up, but I just, since nobody else is saying anything. So my son's been diagnosed with bipolar 1, OCD, ADD, and has always had anxiety his entire life. So my question is this. When I go home today, okay, can you give me something that I can try, to see if I can get like a twist and see if it works with him?
Yeah. Well, first of all, Peter, it sounds like you've got an alphabet soup of diagnostic labels there, right?
Yeah, I got it all in. Check every box.
Yeah, but that's what that proves to me is just that a kid like your son's difficulties, they're so complex that they belie the diagnostic categories. The diagnostic categories don't capture him well, so we end up capturing him with just about everything. And by the way, there are other kids that you can't capture with a single diagnostic label because they don't meet criteria for a diagnosis, but you still have a problem. And you don't need a diagnosis to have a problem, you just have a problem. So, there are different ways that the diagnostic categories sort of leave us short. But what I really want to respond to is, your sort of urgent plea to, what can I do? Can I do something different? And without, again, knowing, how you've tried to manage the behavior so far, this way of working with kids tends to be a big departure. And that's good when you feel like, gosh, I've been around the block and nothing's been working. There's no magic, obviously. And on the other hand, this can work real well, but it's hard stuff. In terms of, I can't tell you one thing to do. What I can tell you that I would start to do is I go on our website, download the thinking skill inventory, and take a look at those skills and check off ones that you think your child is struggling with, and then try to follow the instructions on there to make a list of the highly predictable situations that you find yourself, either battling out with him or just struggling through with him on a daily basis. And I would suggest don't pick the toughest one first. Pick, one of the sort of a little bit of what I call lower hanging fruit of that list of problems, and give a whirl to this process that I described as Plan B. And there's some stuff on our website that will give you more information about it. But basically, what I'm going to ask you to do is try to put up in a real neutral way with him. And starters, just ask a lot of information. Ask for information, gather information from him, just trying to get his perspective on the table, even if it's a perspective you don't even agree with, even if you think it sort of doesn't make any sense. Just gather information about it, and then share your perspective, and be careful not to share any solution. Here's what we're going to do, what you should do, how you need to think about it. Just share your concern about it, and then invite him to see if he could brainstorm any possible ideas about how to handle this, and here's the catch, that would address what he's describing and you're describing at the same time. And it's not magic. I can't promise miracles here. But it could be quite helpful, and there's a bunch more information on the website that could help guide you.
Yeah, that's great, Doctor. Thank you very much. I will do that.
Good luck with things. And please, the other thing is there's a help tab on the website as well. If you're learning more about this and you think, gosh, this could really help me potentially, click that help tab and have us see how we might be able to be helpful either from afar or finding a certified person in your area who knows this approach real well.
Thank you. I will do that very definitely.
And Peter, your question is a question everybody who's listening to this call, whether today or in the future on our web, will be asking of Dr. Ablon, given this is his area of specific expertise. Another question for Dr. Ablon.
Hi, this is Lauren from New Jersey.
Go ahead.
I have a question regarding how you can get the professionals working with your child to realize that the child unfortunately lashes out at them when frustrated because she's unable to communicate. So she may, start calling the aide names and things like that. And we're just trying to get them to understand it's because she doesn't have the skills to express herself.
Right. Yeah, it's, I'm sorry, I didn't catch your first name. I couldn't catch it. What was your?
Lauren.
Lauren. All right, sorry. Yeah, so, Lauren, this is one of the biggest challenges, and I have to say, a great source of frustration for folks, for parents, when you're trying your utmost to help your kid, and the professionals are in your mind sort of missing the boat as to what's going on. It's nothing more frustrating than that, because you're hoping that the professionals are going to be leading the charge. But it's often a reflection of the fact that we professionals are just as guilty of sticking to conventional wisdom and having a hard time sort of seeing things differently. And, that philosophy that I said, kids do well if they can, I believe that about adults, too. I believe that about parents. I believe that about teachers, aides, clinicians, you name it. We all are doing the best we can with what we know and what we have to contend with. But the question is, if your child, for instance, has real lagging skills in the domain of communication, being able to articulate her concerns, let people know what's bothering her, et cetera, and lashes out. Instead, the challenge is, all right, how do you get, sounds like that aide to understand this is skill, not will? The best advice I can give you, well, there's two pieces of advice. One is pass along the knowledge. For instance, pass along one of the books on collaborative problem solving and say, you learned about this. It seems like it might be relevant for your kid. You'd love if they would take a look. But the second piece of advice is you got to be careful not to impose collaborative problem solving on people. In other words, sort of use Plan A to try to get people to do Plan B. What you want to do is make sure that you're giving lots of doses of empathy yourself for the fact that this aide may be dealing with some pretty tough behavior when your child's lashing out at them. And once you've delivered that dose of empathy, then you're trying to sneak in the view that, that this is not how she's wanting to treat you, but I think she's really struggling with some skills. And then what I would do is invite them to sit down with you with that list of skills in front of you and say, do you think we can take a look at this together and see if we can come up with what she's struggling with? And I find that's a massive intervention itself that can be incredibly helpful. And that is just sitting around hypothesizing about skills, because one of the things that happens is the very same person who will say this is willful, they're pushing my buttons, whenever I ask them to get down to work, they're trying to avoid it by lashing out. The very same person that'll say that will also endorse 10 skills on our list of lagging skills that then you're able to say, wow, it sounds like those are, it's almost like a learning disability that she has a hard time with those. And it starts to push this shift in thinking. So that's how I recommend trying to get going with this.
Okay, and what about for the people that do get it, and yet I feel horrible on how she's treating them?
That's exactly right. And the most important thing you can do there is let them know that you feel horrible about how she's treating them, and that it's really hard when she's treating them horribly for everybody not to fall prey to, going back to conventional wisdom, because what's so tough about this, I made this analogy of a learning disability. You know what? It's hard to teach a kid with a learning disability, but it's excruciatingly hard when this kind of a learning disability manifests itself in behavior that is disrespectful, scary, feels unsafe, pushes our buttons, challenges our authority. That's real tough. And so you need to have constant empathy for how hard it is to hang in there in the right mindset when she's behaving this way. Now, the last thing I'd say is to state the obvious. The most important thing is to try to reduce that behavior, that lashing out behavior, as quickly and robustly as possible. And that gets right back to, implementing an approach that's well matched to understanding and helping to build those skills.
Thank you.
You're welcome. Good luck.
Another question on collaborative problem solving.
Yes, I have a question regarding my son who was recently diagnosed with, in addition to all of his other ADHD, ODD, and so on and so forth, he's now been diagnosed with what's called narcissistic personality disorder, and I'm wondering how can we help him with collaborative problem solving?
Yeah. Well, it's tough. I gotta be honest with you that while I don't find diagnostic labels to be particularly helpful, I don't find personality disorder labels to be particularly helpful either, and maybe even less helpful, especially because even if they're not intended this way, they tend to encourage thinking that is fairly blaming, frankly. So, I would just strongly encourage you to not get too hung up in that diagnosis per se, but instead to again try to translate that into skills. I mean, what I say to myself is somebody who looks like they have narcissistic personality disorder, what skills are they not so good at that if they were better at, we wouldn't be calling them that? And then how do I help them practice those skills? And a lot of times, and I would need to know a whole lot more about your son in particular, but a lot of times with that diagnosis, what people are saying is that this is a kid who is incredibly rigid and stuck on his point of view, and cannot take anybody else's perspective into account, doesn't know how he comes across, impacts others, and unfortunately people start to think, doesn't care, isn't interested in that, and I like to remind people, whoa, slow down. You can't even care about how you're coming across, impacting others, what's going on for other people, until you're able to know that, until you have the skills to do that. So it may be, complicated skills like empathy are what he struggles with. And the nice thing is that process I was describing to you before, that 3-step process, it actually asks somebody to practice all those skills every time you do it. The problem is, it's not magic. And so it's not like 1, 2, 3, 4, 5, 10 repetitions of this and you're going to start to see him being a lot more empathic and better perspective taking. It takes a ton of repetition. And, we know more these days about how brains change and develop, and creating new connections, changing the architecture of the brain really, requires tons of small doses repetitively of a different type of interaction. And it needs to be a little bit stressful. Brains only change with a little stress. Good stress, we call it. So small doses again and again and again of this Plan B process can be really helpful to address the kind of skills that often lead to a diagnosis like that.
Thank you.
A lot of good questions from the NAMI community.
Great
question. We have time for a few more questions for Dr. Stuart Ablon.
I got to say, I just want to say that they're great questions, and what I find myself saying to myself is, I wish I could be more helpful, and the way that I would need to be more helpful is to hear a lot more, to do the kind of assessment that in this approach we find helpful, which is getting really specific again about the types of situations in which the challenging behavior occurs, and the types of skills that if the kid were better at, those situations wouldn't occur. And then you can sort of craft a more specific game plan. So it's frustrating to not be able to do that with you all, and sort of do my best to try to provide some guidance about how to get that started.
Well, I think we all appreciate this is a limited, forum, but at least they can be introduced to the ideas, the philosophy, and the work you've been doing. At the end, I'll be asking you about your favorite references that people can turn to make sure that they have access to your thinking.
Great, thank you.
I have another question. Dr. Ablon?
Yes.
This is Alicia from New Jersey. And I've known you for a long time. I am perhaps collaborative problem solving's biggest cheerleader. I found collaborative problem solving when I heard you come to New Jersey to speak 9 years ago. I have a daughter who's now 26, whose challenges started at age 3. She has the alphabet soup. Things were not helping her. When I found collaborative problem solving, it has been a godsend in my life. She has every diagnosis. She has been diagnosed with every diagnosis. Diagnoses didn't tend to help me. What helped me help her was collaborative problem solving. And it is a wonderful model. The question I'd like you to address that I hear over and over again, I will go anywhere and do anything and tell people, this is it. This works wonderfully. I keep having people say to me, so you're telling me if my kid's hitting somebody else or they're running out in the street that I'm supposed to collaboratively problem solve with them at that time? Or what else am I supposed to do? And are you telling me never to use consequences again? Can you explain to folks how that process would work?
Sure, I'd be happy to. Thank you, and it's nice to hear your voice, Alicia. And you are one of the greatest advocates for the work, and I'll take this opportunity to thank you, but also to point out that I think that the way that we're going to turn the tide for these kids is by helping the rest of the world to see these kids differently. And I can't think of better people to do that than the parents of challenging kids. We live in an information age. Let's advocate. Let's get the word out that there's a different way to think about these kids. And I feel like the army of parents out there that know that this is about skill, not will. You are the folks to change the conventional wisdom. So I'm incredibly grateful for the efforts of people like you to turn the tide. You're asking a bunch of crucial questions. The first thing to say is I mentioned there's 3 plans, and we emphasize Plan B the most, but there's a reason that we describe what Plan A is, and it's not just to say don't do it. There's times where you have to do Plan A. You said if a kid's about to run out in front of the street, no, that's not the time to do collaborative problem solving. Absolutely impose your will and don't feel badly about it. But what we then say is when the dust settles, there's nothing about having had to tackle the kid, for instance, that is going to prevent the likelihood of them doing it again if, for instance, poor impulse control is to blame. So the trap we get into is if we end up using a lot of Plan A to try to prevent kids from doing things that are unsafe, we better hope we're around the next time it's about to happen or somebody else is. And this is sort of my biggest indictment of our correctional systems, is we use a lot of Plan A to keep things quiet in there, But if the kid hasn't learned how to handle things on their own independently when they leave, and that's why recidivism rates are so high. So by all means, use Plan A to keep people safe. But as soon as the dust settles, say to yourself, what was the trigger, the antecedent? What are the skills the kid's struggling with? How am I going to use Plan B to solve that problem and build those skills so that when I'm not there next time, we're not going to be in trouble? The other thing I would say is this notion of when do we use consequences? I mean, do we never use consequences? And what I like to say to people is, look, I'm not allergic to consequences. And people sort of accuse me of sometimes being overly critical of behavior modification strategies. And I like to point out to them, I don't think I'm overly critical. What I'm critical of is us using things like consequences for things consequences were never intended to work for, and then being surprised when they don't work and actually make matters worse. And so, like, if you go back to Psychology 101 and you look up these rewards and consequences and things, you'll see that there are versions of what we call operant strategies. And they are good at teaching people basic lessons and motivating people from the outside. Well, if that's what's getting in the way for your kid, they ought to work. But as I started off in this call explaining, these kids they struggle with a lot of skills, complicated thinking skills, what we call neurocognitive skills. And consequences were never intended to teach neurocognitive skills. It's not their fault. They just won't do it. And in fact, they might make it harder to teach them. And I guess the last thing I would say about this is there's this funny irony. It's a bit sad, actually, that for a consequence to be successful or effective, it has to be meaningful and accessible to the kid right at the moment it's needed. So in other words, right before the kid's going to do something we don't want him to do, he's got to be able to stop in his tracks and say, okay, wait a sec, before I do that, here's what happened on Tuesday when I did that, and I didn't really like getting that consequence, so you know what? Let me reel it back in. I don't think I'm going to do that. Let me think about what else I can do because I don't want that consequence. In other words, in the heat of the moment, the child needs to stop and think about the likely consequences of their actions before they act. And that, in fancy language, is what we call impulse control. So what's the sad irony? Well, you need impulse control to benefit from a consequence. And who gets most of the consequences applied to them out in the world? The impulsive kids that don't have the impulse control to benefit from the consequences. So, short answer to your great question, Alicia, is I'm not allergic to consequences, but let's use them for things they work for and not for things that they don't.
Great, thanks.
We have time for a couple more questions, I think.
I've got one going based off of what Alicia was just saying. This is Liz. I'm a clinician from Massachusetts.
All right, good state.
Absolutely. So I guess going off of Alicia's question, I've witnessed a lot of collaborative problem solving, but I'm still kind of new to this model myself. And I've heard a lot about sort of the negotiable and the non-negotiable behaviors. And I'm wondering sort of how that ties into this idea of, when to use collaborative problem solving and when you can't, and how to sort of broach that afterwards.
Right. So a couple of things. One of the mistakes people make is thinking that the goal of collaborative problem solving is to problem solve the behavior. So they try to do Plan B around the behavior. And if you've got a list of problematic behaviors and you're looking at A, B, or C, everybody's going to vote for A and say, well, that's non-negotiable. I mean, he can't verbally insult people. He can't assault people. He can't run away and be unsupervised. Those are non-negotiable. So in other words, they'll fall into all Plan A. But that would actually be sort of a little bit of misunderstanding of the approach, because the approach is saying that the focus is not the maladaptive behavior, which, yes, is non-negotiable. Once it's happening, you're probably going to end up using Plan A. But the target of the approach is the demands or the situations or the triggers that the kid is having a hard time handling because of their lagging skills that then lead to the non-negotiable behavior.
Okay.
And so what you're trying to target with Plan B is the trigger, not the maladaptive behavior that ensues after the trigger. Okay? Because otherwise, people are going to end up putting a lot of stuff, using a lot of Plan A for a lot of stuff because the highest level behaviors are all non-negotiable. And we agree, by the way, there's things kids can't do. But you're going to be doing a lot of A in the heat of the moment if you can't figure out what the triggers and antecedents are. And I guess the last thing I would say about that is, I didn't mention this, but there's really two different forms of Plan B. There's what we call emergency B, and there's proactive B. Emergency B is the heat of the moment, and that's probably when the behavior is happening that you're thinking is non-negotiable. Proactive B is saying there's patterns. When do those non-negotiable behaviors happen? Over predictable triggers. Let's use proactive problem solving to address them long before the next time we see that challenging behavior happen again.
Great. Thank you so much.
My pleasure. Thanks for your interest in the model. I hope you want to continue to learn about it.
Absolutely.
We have time for one more question. Go ahead.
Yes. My name is Catherine, and I'm also a clinician. I wanted to know if you have any type of tools or recommendation in terms of a list of questions that will bring about creative ideas to best work with the client populations that have been mentioned already in the call.
So just so I'm clear, Catherine, are you when you say questions, are you talking about when you're in this process that I'm calling Plan B to try to gather information from the kid, or are you talking about once you're actually trying to problem solve, sort of to facilitate that? Maybe you could clarify just a little bit.
Certainly. To problem solve, sometimes, like, I'm thinking of one case, it's dealing with schizoaffective disorder. So you definitely have to be creative. So I'm thinking about working with clients with complex issues to get to be creative. I mean, sometimes, it'll come to my mind when I'm driving or if I'm just eating a sandwich. But if I have a list, that I can use as a tool. Sometimes I do write some questions down and kind of generate my own list, but depending on the work that I'm doing. However, based on this conference call, I wanted to know if you have a recommendation, whether it's a book you've written or another book that you've read that would actually help clinicians to work best and collaborating with others, getting creative ideas to make the clients better and help to solve their problems. It's all about getting to know the clients, but in the end, if you don't have all that time to get to know the clients, how can we save time and the luxury of time?
Sure. Okay. Got it. So I do have some good references for you. And as a clinician, what I would recommend, there are a number of books on collaborative problem solving out there, some for parents, some for schools, some for clinicians. I'd recommend the treatment manual, which, next year will be in its second decade. It's called Treating Explosive Kids. And it was co-authored by Dr. Ross Green and myself. Yep. Treating Explosive Kids. The subtitle is The Collaborative Problem Solving Approach. And the nice thing about that is there's all kinds of vignettes of examples, verbatim examples of dialogue between clinicians and families and kids that gives good examples of how to facilitate gathering information and brainstorming through guided questions. And there's even a section that talks about, when you're brainstorming solutions and nobody's got any ideas, what are some sort of, very practical strategies for how you, come up with ideas in the first place. So I think you'd find Treating Explosive Kids quite helpful. The other thing is, and I know we're going to talk probably resources shortly, we have a whole training program that starts with introductory training and proceeds to 2.5-day trainings we call Tier 1 and Tier 2 trainings. And for those who actually want to go on to be certified in the approach or even certified to train others in the approach, there's, programs that go on beyond that. So you might find it quite helpful to attend one of those as well.
And how would we find that information, sort of when those trainings would be happening?
Sure. So you go to our website, which is
Perfect transition for our conversation about resources. Go ahead.
All right, great. So you go to our website, which is thinkkids.org. So it's thinkkids.org. And the website, I think, is pretty easy to navigate. There's three main sections, learn, train, and help. Learn is to learn about the approach and the research on it. Train is to learn about trainings. Help is to get help. So, pretty easy to navigate in those ways. And if you, use social media, if you become a fan of our Facebook page or follow us on Twitter, you'll also, get all the latest information about trainings as well. We host Tier 1 and Tier 2 trainings twice a year in Boston at Mass General, January and February, and July and August. But we and our certified trainers around North America provide frequent trainings in other parts of the world as well, and we also come to places that want us to do training.
So this is a good time for me to ask people to unmute themselves and sing out a NAMI thank you to Dr. Stuart Ablon for what I think was a great discussion of this important approach. So if you're all just comfortable just singing out a thank you.
Thank you.
Thank you, Dr. Ablon.
So much. Thank you very much.
Thank you, Dr. Ablon. It's greatly appreciated. We hope to have you back in a year or two as your career goes forward and your work goes forward. Have a great day. Have a great day. Thank you.
You too.
Thank you very much, everybody.
That was a good call. Thank you.
Bye-bye.
Well, all those beeps, Dr. Ablon, are people who are